Hi everybody, Dr. Britt Talley Daniel MD, a neurologist, headache doctor, and I have a bunch of YouTube videos on migraine. Here's another one coming right up at you. The title here today is When to Start Preventive Therapy for Migraine, which is a question everybody wants to know. So what does preventive therapy mean? Well, it means prophylactic therapy. It's another word for the same thing. It also means daily medication. And the physician offers this to a patient is wanting the patient to take a daily drug every day for some period of time to see if it'll help for the migraine. We want to decrease the intensity and frequency of the headaches. And it's really a drug trial. So I ask patients to take the drug for 6 to 8 weeks, to do a headache diary, to count their headaches and how frequent they are, and look at that kind of thing and see if the medicine's helping. A lot of people want to take it 1 or 2 weeks and stop and say that it doesn't work. But I encourage patients to take it for a period of time to give it a fair chance, 6 to 8 weeks. So the question here today is, when to start preventive therapy for migraine? And preventive therapy should be considered for patients who, and I have a list of things that would be in the thinking about this. First of all, patients who experience 3 to 4 migraines a month. The American Family Physicians Group years ago had said that. And if I see somebody who's having 3 or 4 migraines a month, I'll mention that to them and say, well, according to the powers that be, you qualify for taking a preventive drug for migraine. You want to do that? Many patients say yes, some say no. Then it's up to them. But if I see someone having 7 to 10 migraines a month, I get more emphatic and try to really get the patient on that because it'll help. They should consider preventive therapy if they have chronic migraine. Now, chronic migraine is defined by the International Classification of Headache as being 15 headache days a month, 8 of which have migraine features. And the migraine features are severe headache on a scale of 1 to 10 migraines are 5 to 10. A lot of my patients tell me they're 20, joking with me. The headaches are usually one-sided, associated with sensitivity to light and sound and odors. They're throbbing in nature and severe and disabling, so the patient's in bed, can't go to work. All right, another issue would be if the patient presents to the doctor with medication overuse headache. Well, wow, that's the #1 presenting diagnosis in a headache practice anyway. So the #1 presenting diagnosis is medication overuse headache, and that's found 80 to 90% of the time if a patient sees a headache doctor. So all of us who do that kind of work get to be very accustomed to dealing with patients like that. So medication overuse headache in patients who usually have migraine, they may know it or they may not know it. It can also happen with tension type headache. And these are people who take many headache medicines and they'll give them a headache by doing that. It's also recommended for patients who prefer that kind of therapy. They're glad to have some kind of medication the doctor can give them and reduce the intensity and the frequency of the headaches. It's also recommended for patients who have significant pain that hampers their life or is disabling them, so they can't get up on Saturday morning and go to their son's soccer game or do whatever was planned on the weekends. They've got a headache and have to stay in bed. Because again, migraine is disabling. It's found for people who take a lot of headache medicines like over-the-counters, NSAIDs, that's non-steroidal anti-inflammatory drugs like Tylenol, Advil, Aleve, naproxen, or any opiate narcotics like hydrocodone or tramadol, or barbiturate drugs like Fiorinol. It's also recommended for patients who don't get significant relief from the acute therapy drugs they're taking, like triptans don't do it. And if they take a preventive drug, it seems to help with acute therapy as well. And also would be recommended for patients who have side effects from acute therapy. All right, the related questions regarding this. So for whom may preventive treatment not be a good option? Well, patients who can control their headaches pretty well with NSAIDs, they take a triptan, once or twice a week. They're not over-treating. They don't have medication for headache. And then they could add in a little Advil or Tylenol or caffeine and get rid of their headaches. They probably don't need preventive therapy then. Patients who have other health conditions that might interfere or be contraindicated with taking the drugs. Patient may already be taking a drug from another doctor for some kind of problem that you couldn't use a preventive. An example of that for me always has been patient sees an internist, they have high blood pressure, they're taking Inderal. Well, then I won't give Inderal as a preventive drug for migraine in that situation. I had to think of something else to do there. You'll be found for people who really prefer treatments so they don't have to take medications. That's pretty unusual, but some people want that. They can get relief by hard exercise, relaxation therapy, stress management, learning how to do cognitive behavioral therapy, or doing biofeedback. Patients sometimes prefer some kind of device. We have a couple of devices that can be helpful and recommended by the FDA for treating chronic migraine, and one of them is Cephaly, which is an approved drug for treatment. It's like a device that's on the head, and develops little electrical impulses that go in the head. It's used once a day for 20 minutes, so the patient could also consider getting on gamma core for treatment, which is a vagus nerve stimulator. Looks like a little stimulator you put on the neck, and give treatment for migraine that way. There's also a group of patients who are pregnant. Of course, no doctor should be thinking about giving a medication to any woman who's pregnant other than vitamins and iron. We don't want to do that unless we have to. And also because most patients who have migraine get pregnant, they get better in the second and third trimester when estrogen levels rise up. All right, what are the American Academy of Neurology and American Headache Society recommendations for drugs that can be used as preventive drugs? And they have three classes here. Level A is the first, and these are drugs which have been found to be established as effective. These drugs are valproate sodium, sodium valproate, which is the old Depakote, Topamax or topiramate, that's generic. That's a short-acting drug that has to be taken twice a day or every 12 hours. And then we have long-acting once-a-day drugs, which are Trokendi XR and Qdexia XR. Sometimes we will use Frovatriptan, which is a long-acting triptan that lasts 26 hours for ladies that have menstrual migraines. They may have a headache lasting 7 days during the menstrual cycle, and you can use Frovatriptan in that situation. Or then Onanabolotoxin A, Botox, where the physician injects 31 injections in the patient's forehead, head, and back of their neck every 3 months. When that's effective, it's repeated every 3 months. It's been indicated by the FDA for treatment with patients with chronic migraine. But, however, Botox has been found to be only modestly effective for preventing migraines in the most frequent sufferers. So what it can do is it can prevent 1.8 headaches a month, getting these 31 shots every 3 months, more than placebo. So it has a weak effect. We can also take beta blockers that are helpful for chronic therapy, and these are metoprolol, Inderal, and Timolol. And then they're listing of drugs that are level B. These are drugs that are probably effective, and these are amitriptyline, nortriptyline, and venlafaxine. Those are drugs like antidepressants used for anxiety. And then level C drugs that are possibly effective. And what I got here is ACE inhibitors such as lisinopril, angiotensin receptor blockers like candesartan, alpha agonists like clonidine, carbamazepine, which is a drug for epilepsy, cyproheptadine, which is really like an antihistamine drug, atenolol, and guanfacine. Now, there are special considerations where the doctor can give a drug and treat several neurologic problems, which is great if you can do it. For instance, patients who have epilepsy might give a trial of topiramate or Topamax drugs, because those are indicated for treating epilepsy and migraine. You can get kind of a 2-for-1 treatment deal there. But again, that's best for men patients, and it's not indicated to give Depakote, which also has a similar side effect treatment profile, but Depakote should not be given to women who are fertile, because it can cause damage to a baby. Also, patients who have tremor, hypertension, or migraine could be given a beta blocker and treat all three of those things. Or patients who are anxious or a little depressed, you can use amitriptyline or nortriptyline in those situations. Thinking again that way, the doctor and patient can get a double whammy for one drug. Now, the new question on everybody's mind at this time is, what's the effect of the new CGRP drugs that came out in 2018? They're so effective now for chronic migraine. And the problem there is we just don't have any data. Although the FDA has approved Aimovig and Ajovy and Emgality for preventive therapy for migraine, we did not have any studies that have been done comparing them with older drugs. So we'll have to wait till that comes out. I would think they would, but stay tuned for new data on CGRP drugs. So that's the statement I've got on this, when to treat migraine, preventive migraine. God bless all you patients with migraine. I hope you're doing well. I'll see you on the next talk.